So these are the subheadings under which we will try to uh, deal with and try to understand this topic. So I'm sure you all have already come across the different types. So for example, on the basis of the ECG, whenever you come across, what will happen is if we try to look this position of the different leads, surface ECG leads. So what happens is lead V3 and V4 are the ones which is facing the anterior wall of the left ventricle, okay? And coming to the blood supply, the one which supplies, um, the LED and the circumflex arteries are the ones which come out through the branches of the left main, in fact. And this is the reason if there is an occlusion in the left main, so this is what is called as widow maker. So the death rate is quite a lot high, and that is the one which leads to cardiogenic shock and also death without any prompt reperfusion. So as you can see it over here, over here comes the left main artery, okay? And if this is getting occluded, of course, the further branches will be getting occluded, and the mortality is thus very high because the heart muscles over here, they will not be able to pump over here at all. So this is the reason we all have to be careful. So as I was telling you, so what happens is if you look carefully, we all are aware the inferior segment is determined by the 2-3 AVF. The lateral segment is like 1 and AVL and V5 V6 as well, okay? Then anterior segment, for example, goes to V1 to V6, in which V1 to V2 mostly represents the septum, and V3 to V4, as I was telling you, it is more of anterior, and V5 V6 is the one which is representing the lateral area, okay? So what happens in the anteroseptal MI? The different types of anterior wall MI. So anteroseptal is represented by V1 and V2, and maybe sometimes, of course, V3 as well. So the changes may be seen, for example, ranging from V1 to V3 at the most, and ST elevations is going to be there, in fact. And yes, unlike all other myocardial infarctions, if it has already evolved, you will start seeing the Q waves as well over there. And what is happening in the inferior wall? So as I was telling you, inferior wall, at least on the surface ECG, is represented by 2-3 AVF. And the blood supply for this, most of the times, it is happening is through the RCA, in fact. And yes, it does have its own branches as well, okay, which you can see it over here. So if even in the inferior wall MI, as I was telling you, so what happens is 2-3 AVF is the one which normally deals with it. So the inferior wall, uh, as you can see it over here, there is a big area of it. So this is why they are of two types further in the inferior wall. One is called the right ventricular MI and the posterior wall MI. Especially in the RVMI, what happens is in the ECG. So for example, over here, okay, let me give you, without seeing the angiography, how can you predict? So this is the typical ECG of 2-3 AVF, ST elevation is there. So yes, inferior wall MI is there. However, if you look carefully, the ST elevation in lead 3 is more than lead 2. So possible RCA. And if it is vice versa, this will be LCX. Okay? I hope I'm clear. LCX versus RCA. This is how you differentiate which is the possible site of occlusion. In the lateral wall MI, as I was telling you, the lateral wall is represented by V5, V6, and also the 1 AVL. So most commonly it may be affecting all four of them. Otherwise, something is called as extensive high lateral wall MI, so in which only 1 and AVL may be only getting affected as well. So that can also sometimes happen, in fact. And coming to the other inferior type of, okay, We will show you some examples and then we will discuss about that. So lateral wall MI, as I was telling you, so what happens is, in this, if we see one in AVL, there's ST elevation. So that is why it is lateral wall MI. And in the septal MI, as I had already said it, so you should look in the V1 and V2. Okay, so because these are the areas which is close to the septum. So if you'll try to recall, Bashant Sharma, can you please mute your microphone? Raj Shekhar, oh my gosh, please mute your microphones. Mute your microphones. Hello? Okay, so we were talking about septal MI. As I was telling you, so you should look at this area. So if we may recall about the placement of the leads on the chest wall, so that's what we noticed, right? So the other thing as well to be noticed is sometimes you may also notice is if there's poor progression of the R wave. Poor progression of R wave means, so what happens is normally you'll start noticing by in the V2 the R wave will be slightly a bit longer. And in V3 the transition is about to happen in fact. However, for example, if you come across an ECG in which V1 to V3, there's nothing, hardly any progression at all. So you should start suspecting that. You should always try to be looking for the QS wave pattern, especially in the V1. If there is QS in the V1, there's no doubt about it. It is a septal infarction and you should proceed accordingly, in fact. So as I was talking about the posterior wall MI, so what happens? So this is how is the posterior wall. This colored area over here. Okay, so there are multiple coronaries vessels which come and do the blood supply over here, in fact, okay, which do the supply, and that is very important to be able to understand as well. So that is why if you come across any posterior wall myocardial infarction, these are the problems you are going to come across. So what you happens is, as I was telling you, so normally we all are aware these are the leads. However, if you want to see the real posterior wall MI, you should try to put those leads like V7, 8, and 9. So what happens is uh, you have to go slightly a bit posterior. So in the posterior scapular region and in mm, where you have to keep these leads. Okay, you can read it as well in details. So as I was telling you, so what happens is where you keep them, which the common question is where shall we be keeping? So this is where you keep them. So as I was telling, so this is the interscapular line. So one at the beginning, one in the middle, and towards the end. So almost parallel to the vertebral line. And if you're thinking, for example, for the right ventricular MI, two things are there. So posterior wall MI, you should ideally keep it in the back. Right ventricular MI, you can also do it from the back, but the more common thing or the more scientifically practiced thing is to put them in the front. Okay. So now coming to the posterior wall infarction. So as I was telling you, whenever there are inferior wall changes, so that is where you have to start looking for if it is posterior wall or if it is right ventricular. So if there is inferior wall MI, so you should start looking in the V1 to those anterior leads. So for example, like V1 to V6 or V1 to V4. If you see mirror-like changes, mirror-like changes, mirror-like changes, you should start thinking that most likely it is a posterior wall. So to confirm that, what you do is you are going to put those leads in the posterior wall. And as we already showed to you where you put that, right? And you can put it over there and you will be able to notice it. So already I said it about the localization. So for example, you will, for example, about the possible culprit artery, you should look forward, for example, in the lead 2 and 3. So if there is higher ST elevation in lead 2 compared to 3, it should be possible LCX lesion. Similarly, if there is higher ST elevation in lead 3 compared to lead 2, you should suspect there is possible RCA occlusion. Okay, this is a big thing in the sense like no need to even bother about the uh, no need to get bothered at all about the angiography, in fact. So clinical signs are very important. So now coming to the other important thing about the inferior wall MI. So as I was saying, so there can be also possible RVMI, right ventricular myocardial infarction. So if you may see, this is the right sided zone. As you may be able to notice, it looks like over here, as you may see over here. So this is the one over here, yeah, and the right sided zone over here. And what you will notice over here, if you want to document it, you should put some leads into that region, right? Because our surface chest ECGs are in this other side, right? Not in this side. So that's why if you want to document it, put the leads in V4R, V5R, and V6R. Okay. So as I was telling you, so these are the areas where you put it up. So V1, you know it over here. So then comes the V4R, V5R, and V6, in fact. And yes, of course, you are in the hurry. No need to put up everything. Just V4R should be pretty good enough. So what happens? As I was already telling you, what happens is in the acute phases. So for example, if you look carefully, especially in the lead V1 or V2, there's slight ST elevation, right? So rather than that convex pattern, which was there for the posterior wall MI, convex pattern, and this you look, there's a ST elevation over here, right? So this will be one of the important things which we all have to be careful over here. So I hope you all can understand it. So what is now one question for everyone? Please use the chat box. Why we are interested in classifying those inferior wall MI? Please tell me. What is the clinical significance for that? Okay, good, good. Some more. Okay. So to understand which artery is blocked, yeah. Preload, okay. Preload, good. So what happens is even the complications. So what kind of complications are we anticipating in such patients? That also can be anticipated. Good. Okay. The probably the damaged area, wonderful. And what else? What else? Mm-hmm. Please mute your microphone, Savitri. So, as I was telling you, what happens is why we have to differentiate them because they are associated with different kind of problems. So RVMI is the one which is notorious not only to land up into the complete heart block, but also they are predisposed for ruptures and hypertension. So if there is a patient who is coming with RVMI, you should always be ready with your temporary pacing wire and also support as well. You should be ready for that. So that is where you have to be really, really careful for all these things for sure. Okay, so this is why you have to classify. You have to be able to classify what type of it, the myocardial infarction as well. So as you can see it over here, the RVMI is associated with a clinical triad of hypotension, jugular venous distension, and also clear breath sounds. So in fact, yes, that is also true. Is in the sense like although only 10 to 15% of the patients with the RVMI presents with these signs and symptoms, in fact, okay? So that is why you have to be a bit extra careful for that, what needs to be done, how it needs to be taken care as well, yeah? So we all are already, I think, experts by now to how to be able to see the ST segment and how to be able to pinpoint that there is a myocardial infarction, right? So what is the most important thing is what is called as ST segment. We all are aware of the PR segment, the QRS duration, and then comes the ST segment. So ST segment is important in terms of ST elevation and depression. So ST elevation is the one which does indicate ST elevation MI, okay? And to be called as significant, at least there should be a minimum 1 millimeter ST elevation for sure, okay? So 1 mm of ST elevation, especially in those limb leads, and to call it, if you're calling in the precordial leads, at least it should be around 2 millimeters in the precordial leads, okay? And at least two anatomically contiguous leads. Two anatomically contiguous leads means is, for example, if you're talking about the lateral wall, so at least either one AVL, at least two, I would say, one AVL, V5, V6. Other similarly, if you're talking about the anterior wall, so for example, V1, V2, otherwise V2, V3, V3, V4, like that. Similarly, if you're talking about the inferior leads, inferior wall MI, it should be there in the lead 2, 3, otherwise 3 AVF, like that, okay? Then comes is the ST depression. ST depression, how you say it, so there is a down sloping changes in the ST segment, and to call it as non-ST elevation. So, for example, over here, as you may see, at least half millimeter, half millimeter is important. So over there, for example, if we can see, we could recall like even zero point 0.1 millimeter was pretty good enough. But over here to call it as ST non-ST elevation MI, at least 0.5 mm is very important. And similarly, it must be present at least in the two anatomically contiguous leads for sure. Okay. Now, how about the evolution of an MI? For example, what are the patterns do we see on the ECG? So, as I was telling you, there are various patterns in which we may be able to see those changes in the form of ischemia, injury, infarction, and Q waves. So, for example, if it is ischemia, you may be able to see there may be associated ST depression and T wave inversion. And if it is injury, of course, you will be able to notice there's ST elevation, or even for infarction as well. And if you notice Q wave, so it has already evolved, and you notice that. So whenever we are seeing the ECG, so I already try to highlight it, right? So what are those areas? So as I was telling you, so anterior will go up to V1 to V4 literally. The lateral is V5, V6. The high lateral is like 1 in AVL, and inferior, as I said it, so 2, 3, and AVF. And the right side, if you really want to comment upon, so as I said it, one may look at the AVR, but as I was telling you, so for example, if there is a associated inferior wall MI, try to have a look on the V1, V2 as well. And why is that? To be able to differentiate, is it a RVMI or posterior wall MI? So as I had said it, if there is an inferior wall MI and V1, V2, for example, if there is slight ST elevation, then you are going to notice is there will be RVMI, right? Okay, so if you will recall the anatomy of the heart, so these are the different segments. So what is called as grouped leads, which represent the different areas. So we already said about it. This is the inferior wall of the heart. Then here comes the septum, this zone, and here comes is the anterior wall. And this is the reason. So anterior wall is extensive, right? And this is the reason. If there's a blood vessel supply to this area is getting affected, that's where you may anticipate those kind of problems as well. And the lateral wall, as we had already said, it is one in AVL as well, is there in fact. So these are those different vessels which may be playing an important role if you're trying to think about the anterior wall.